Welcome to the DIO Centering the Margin series. I'm Marlena Duncan, Vice Chancellor for Diversity and Inclusion. And the Centering the Margin series really is an informal venue designed to spark inquiry and innovation in the DEI space. All of our Centering the Margins talks focus on the unique perspective related to the experiences of diverse populations. The series intentionally centers on the narratives of silenced communities and aims to create an educational space for participants to discuss the systemic barriers that impact marginalized groups. This academic year, we're focusing on the wide and varied BIPOC community. And the BIPOC acronym stands for Black, Indigenous, People of Color. And it's being used to acknowledge that Black and Indigenous people are severely impacted by systemic racial injustices in our country. So today's topic, we're going to focus on racism in medicine. And, just within the last, I would say 5 years, racism has been identified as a public health crisis. And I think that's a great thing because positioning the longstanding issue of racism as a public health crisis is not just a matter of semantics. I really believe and hope that framing racism as a public health issue should compel organizations like UMass and other government units to address the crisis in a broad, systemic way, that other threats to public health have been addressed over time. So, that would include strategic initiatives and planning around policies or practices, education, support services, and not just, focus on changing individuals' behaviors and beliefs, but really looking at the system. So this afternoon, our conversation is going to focus on that aspect of racism in medicine. How can we really focus on the structural and institutional barriers that impact racism in medicine? And I have the pleasure of being joined by Drs. Fan, Numba, Carrasquillo Vega, and these are all medical professionals of color in our UMass system. And they have graciously offered to spend their time with us this afternoon, engaging in this really important conversation. So I'm going to start with just asking them to introduce themselves, what they do here at UMass, and their why. Why is this important to you? Why did you decide to join us for this conversation? So I'll start with Dr. Fan.
Well, thank you, Dr. Duncan. So I'm P.Y. Fan. I'm actually a transplant nephrologist. I'm a kidney doctor who focuses on kidney transplant, and that's perhaps the place that I've had the most involvement in this particular issue. I've served as the chair of the Minority Affairs Committee of the United Network of Organ Sharing, which happens to be the group that oversees all transplants in the United States. And the focus of that group and the work that we did over an 8-year span or so was to try to break down the barriers that have led to the well-documented limited access to transplant for minorities, particularly for Black recipients. And that's the work that I've done at a national level and got my interest and has really had me going on this for quite a long time. At UMass, I've been here a long time. I've been here 28 years, and I've benefited from the supportive and collegial atmosphere here, but you cannot help noticing after this length of time that our community is not as diverse as it should be. That is especially true in the leadership positions. In my nearly 30 years here, I can count until the last 12 months, I can count only 2 division chiefs in the Department of Medicine who were of color. Again, that is something that's quite striking. And so at the local level, that's something that I'm involved in trying to change, and through my role as a vice chair of the Department for Education. And I'll stop there.
Thank you. Dr. Numba, you can go next.
Hi, I am Natalie Numba. I'm an assistant professor in the Department of Psychiatry at the medical school. I'm actually a psychologist by training and a forensic psychologist by practice. So I practice at the intersection of the mental health and the criminal justice systems. I'm co-director of the law and psychiatry program within the psychiatry department. So I oversee a lot of the training and education that UMass does in terms of forensic mental health assessment. And this is a topic that's been, of interest to me for quite some time, in part because of sort of personal experiences of isolation sort of throughout my career. And then also because, I'm one of the people asking some hard questions about our field and, out of a position of sort of respect and a belief that, we can really do a lot of good things and be very ethical practitioners. So toward that end, I do a lot of training of students, mental health professional trainees, and mental health professionals, where I encourage and prompt people to really sort of think through matters of race and ethnicity and culture and equity, for all sorts of aspects of identity. And I'll leave off there. Thank you.
Thank you. And last but not least, Dr. Carrasquillo Vega.
Hello, everyone. I'm Joel. I'm part of the hospital medicine team. I've been here since, as a faculty member since 2016. I am originally from Puerto Rico, and I did medical school there, and I did residency here at UMass. Finished in 2016, and I stay here as a faculty member. I'm currently the director for hospital medicine at Marlborough Hospital, which is one of our community sites. And as of the past several months, I'm the Chief Diversity, Inclusion, and Social Justice Officer for the Department of Medicine. And this piece is really really important for me. If you think about it, even back in medical school, back in Puerto Rico, I experienced some of this, just starting early in my career, but during COVID mainly, I'm part of the Army Reserves, and I got deployed to New York in the first wave of COVID-19 in Queens Hospital Center. And there I lived on a daily basis, the impact that this terrible disease has on African Americans and Latinos. And since then, that sparked mainly my interest in doing some work. I mean, now I'm in a position that I can affect some change, some good work, and why not? And now here at UMass, in this great community of great leaders, we should emulate, or we should deliver some great care for the community that we serve. And unfortunately, that there is a mismatch of the community that we serve and the community of providers that we provide to our community. And that's one of the reasons I'm here, and really glad to be part of this conversation and where we can achieve what we can achieve as team members.
So I'm going to start with just the question around, how do we see institutional and structural racism operating here in the Worcester community and the UMass community? Just throwing that out to the panel to share how we see this operating.
I don't want to always start out, but I can start the first one.
Okay.
I'm going to look to my co-panelists to please jump in on some of these. I think one of the things, as I mentioned, Yoel has already pointed out that we as a school and our faculty in particular, maybe not so much the staff, but our faculty doesn't look like the patients that we serve. and the community is not as diverse as it should be. And when we look at it, we really would like to recruit more people, but more people of color to help work here, yet it doesn't ever seem to change. And one of the things that we've looked at would be, well, how do we select the people that we recruit here? And clearly, if you keep doing the same thing over and over again, you have to be pretty much nuts to think you're going to get a different result over time. And so we have to look at what we're doing and start thinking about what kind of change. That's one piece that I think we certainly see. We've talked about it, how when you consider bias and racism, most people jump to the extremes and think about somebody who is, using racial slurs or burning a cross on somebody's lawn, whereas the damaging effects of those actions are terrible, but so obvious and so easy to sort of condemn. What's much harder are the more subtle things that go on that are more cooked into our system, where an opportunity comes up for someone to get special training or some type of opportunity for advancement, and somehow the same individuals keep getting passed over and over again. That's something that I think we do see, and it's not as easy to sort of point out. So that I think is one of the key elements of structural bias that we're going to struggle with in our institution.
I think along those lines, when we talk about systemic racism, I think if you ask the general population, they always come to is a matter of color, is a matter of race. And it's not until you start working in this space that you figure out that it's more than that. It's a lot that goes on behind the lines. So we have to take a step back from a system-wise or as an organization. What practices, what policies that we have in place that to some extent penalize or kind of like exploit our people of color, our people in certain races. And not only that, the issue is that affects the attitude, the belief, the behaviors of those persons, and ultimately engagement. And that's the worst thing that you're gonna have as an organization, is a very poorly engaged employee pool. So we have to take that, racism as a race, and not only, race as many people think as a genetic component. You were born Puerto Rican, you were born Latino, you were born Asian. Rather than that, what is a social construct that, this culture is putting behind that?
Yeah, and I would add to that, to carry on Dr. Phan's point, people do tend to focus on discrimination, racism, et cetera, as sort of interactions between individuals. And so the reality is that this occurs at a variety of levels. So individual, yes, institutional and organizational, and then also sort of the larger social level. And these levels all kind of interact with each other and sort of reinforce each other. And of course, it takes a lot of forms. So there's, legal, illegal, sort of the overt and blatant stuff that's very easy to identify versus the covert, subtle stuff that maybe a part of your mind kind of picks up on and then sort of replays over and over later, but it's really kind of hard to put your finger on it. And then there's the invisible. And so what happens is that the focus tends to be on sort of the, individuals being mean to each other, but then we kind of miss out on some of the larger, issues. So for instance, residential segregation is a significant contributor, that started a very, very long time ago with laws and policies that were sort of designed to protect, sort of this small group of people and their property, which then leads to the diversion of certain resources. So for instance, educational segregation, and then the funding of education by way of property taxes, which means that if you don't live in a ritzy area, then you miss out on some, educational opportunities, which then feeds into things such as education and employment and having access to that. And then of course matters of policing and over policing, which then ushers people into the criminal justice system. And these systems tend to be very, very powerful, but at the same time, very invisible. So sort of in the way that fish don't see the water that they're swimming in, we don't see sort of this atmosphere. And so when the atmosphere is poisonous or toxic, maybe we see some of the, the disease and the detriment that comes from it, but it's hard to sort of pinpoint the cause because it seems so invisible. But really what it is that it's pervasive, and it's showing up in a lot of systems in a way that interact with each other and kind of build on each other.
So thank you all for those answers. And I think I also want to help us address the other elephant in the room, right? So why is it so hard to talk about this in the context of racism? Why is it so hard for us to say the word, to address it, to normalize these types of conversations?
So I think I have some sort of theories or thoughts to kind of add to that. So, and then just to kind of take a historical sort of a view. So before, and speaking of racism specifically, and I want to make it clear that there's lots of forms of oppression and marginalization tied to many aspects of identities. And so we need to acknowledge that. I'm just going to focus for the moment on race. But sort of there was this very sort of intentional sort of marginalization. So for instance, the 3/5 compromise, going all the way back there to, Jim Crow laws and et cetera, et cetera. So, but what happened since then was the civil rights era, right? Where it became illegal to be, to discriminate. And then, people can get in trouble and companies can get in trouble, especially companies that are large and have resources that they can lose in expensive lawsuits, and then just combine that with sort of this American ideal of, meritocracy and fairness and equality, it becomes more about, sort of reinforcing or just saying, oh, we're all equals, we're all this, we're all that. And then, talking about inequity or acknowledging it or acknowledging one's role in it becomes, dangerous or threatening. It can be a threat to somebody's sort of concept of themselves as, as a good person or as somebody who, acts with good intentions or wants to be fair and doesn't want to see oneself as mistreating others or perpetuating the mistreatment of others. So it can be really, really tough to to acknowledge. And for some people, especially for people who don't see themselves as having, privilege or things like that, it can be a real kind of threat.
I can add that on a personal level, why is so hard? Sitting down and talking about this. Why is so hard? And on a personal level, I think about talking about it, you might find that actually your behavior is erroneous and is racist. People, perhaps it's hard to talk about it from a position of fear that actually you are part of, and to some extent part of the problem. And I think, that could translate on a systematic level and on an organizational level as well.
A lot of it too is that, at the root of all this is that things have been unfair, right? I mean, that's what racism is. It's being unfair to a certain group of individuals. But the unfairness has gone on for a long time. And getting back to Natalie's point about the sort of meritocracies and everyone's equal, well, that's not really true, right? When you're born, so many of the things that you have as in terms of opportunities relate to the stature and status of your family. whether they're middle class, whether they're upper class, there's so many things that play into it that have nothing to do with how hard you worked. And but we have this myth that, if you work really hard, you can always succeed, but that's not really true. There are so many advantages that the person that comes from a more privileged background is always very much advantaged. And if you look at what's gone on through the centuries, we have such a huge schism in the United States between rich and poor, but that's very true for particularly, our Black citizens. They essentially, I think I saw a recent statistic that said the median income for a family of 4 who were white was something like 10-fold higher than the median income for a Black family, a similar Black family. And that's not because that's because of things that have happened many, many years ago. So when you want to have that conversation, you have to ask the person who's been in a privileged position to think about, A, that they were privileged, which nobody wants to think of. They want to think they did it all on their own. And the second part is that, well, if you're going to correct it, you got to take something away. And, we all know it depends on whose ox is being gored, right? I mean, it's all great and everybody supports it until they got to give something up. All of us do this. And that's where it really gets nasty and it becomes uncomfortable for people because they can kind of see where this is headed.
And I would add to it, it's easy to be comfortable. It's easy to be comfortable and secure. And then, having to do some of this work, it's hard. And at times the benefit isn't going to be immediatly apparent. It's going to, feel like pushing a very heavy boulder uphill and trying and straining and not seeing any sort of immediate payoff.
So as we think about that, the way that Natalie just ended it, this huge boulder that we're pushing uphill, that can feel overwhelming as well. And so given that we're talking about racism in medicine, what is the urgency around pushing that big boulder uphill?
So my immediate response is to look at how COVID affected Worcester and who's getting infected and who's dying, and realizing that that doesn't just come from nowhere. COVID really sort of magnified, the issues, the schisms, the problems that have been going on, that have been brewing. And, now that we have a global pandemic, which is a major catastrophe, you can see this in who is taking the brunt of it in terms of who's getting infected and who's most at risk because of their occupation, for instance. Some people can't work from home. And some people can't quarantine, where you just stay at home for like 2 weeks. You got to pay your bills, or you're living with a bunch of people that you're sharing space with. And so I would say that that's urgency, given just the high amount of people who have died, yes, but then also the people who remain chronically ill and the people who are experiencing the after effects of COVID infection from, brain fog to, issues with their lungs and so on and so forth.
I mean, from an importance standpoint, everyone should strive for this, right? And gladly, to some extent, COVID has put that focus on this. This has been going on for years. This years and years, in and out, we've seen disparities, racial injustice, especially in medicine. But thanks to recent movements, thanks to the COVID-19 pandemic to some extent, there is a lot of, you can call it hype, like across the US, multiple institutions have now put the interest in diversity, equity, because they know the importance of this. And I think the time is now. We should thrive on these efforts. We should thrive on this wave. If we have a chance, is now. My hope is that this is not a wave. And once COVID goes away, this ends and everyone put, all right, diversity and equity, all right, let's just put it on a say complaint. This is so important, not because this is, you know, the latest thing on the streets, but because this is the right thing to do, not only for our patients, that's what we are here for, but also for us as co-workers and employees of a big institution.
I have to admit, I'm not as, there's probably data on this already, and I'm not completely familiar with it. But even if you're nothing but a bean counter, I think if you look at correcting anything, and you look at how much the United States spends on healthcare, it's mainly on the people that get acutely ill. Well, we just got done saying that that's disproportionately people of color. And they don't just get a little ill, they get really ill. There's just not even to take into account the human cost of this, just looking at the dollars. We need to do something to affect this. And tertiary care, taking care of people once they're sick enough to get into the hospital, is like the worst way to do that. And so the only way to sort of improve this would be to sort of get at the preventative side of it, the grassroots side, which is to improve the overall health of communities that are disadvantaged right now. Those are predominantly communities where people of color live. And so it is a big healthcare crisis, and it would be helpful from not just a medical and social perspective, but even if you just care about money, it would probably be helpful from an economic perspective.
Thank you. So centering the margins, we want this to be a conversation. So we invite now the audience to ask questions or make comments around, again, this very important topic of racism in medicine. How do we dismantle some of these structures that we know are, as Natalie brought up, almost invisible, right? That we don't even notice them at times, but we do need to take the time to pause and figure out what are they, and then how do we dismantle them? So if people are more comfortable writing questions in the chat, you can do that. Or if you just like to unmute yourself and speak, we also welcome comments.
So when we're talking about care that people are getting only in emergencies, both St. Vincent's or the Fallon Plan, whatever it is, and UMass have urgent care centers. Now, there are a number on the east side of Worcester. I don't know is how many have come into the city of Worcester. And I think you can start there, because if you don't have a physician, don't want to go to the emergency room, at least an urgent care center is a place to start. And some of the urgent care centers have actually have their offices for practice the urgent care center. And says, anyone looked at that to see how that's being distributed and which ones have a diverse group of patients?
I'm not aware of anybody who's actually systematically looked at where urgent care centers are located, Josh. But I would suspect that the distribution is going to be similar to things like grocery stores, where they don't tend to go to communities that are disadvantaged and are less likely to have patients that can afford to pay for that kind of care. As just to kind of strike close to home, UMass is embroiled in this argument with the 800-pound gorilla on the Massachusetts healthcare block, the Mass General Brigham Group, and they're looking to build satellite units out in central Massachusetts, but they're not putting them in the middle of Worcester. They're putting them in nicer communities, out here, and I think it's kind of the same sort of thing. You kind of go where the money is. And my guess would be that most urgent cares are kind of similar to that. It would be a guess, but I think that's probably going to be the case.
So how can we change that? I mean, does that mean getting the hospital? I mean, we have a hospital associated with the medical school, and that means working with the hospital to try to change it. Now, not all people are insured. Certainly there's Medicaid, and there's health. So maybe and I don't know if any of these places are profitable, but no matter whether they're profitable or not, you can still put them in different areas of the city and make sure you're taking care of all the people in the city of Worcester and then in surrounding areas. So is there a forum in the hospital? Like we have a faculty council. I don't know if any of you are aware of it. And also, which is a council of faculty members. PY knows about it. And also we have an executive committee here, which is the council, which is basically a council chairs. And these meetings are open, as far as I know. So it would be, it might be useful, and I don't know if there's anything on the hospital side, but it might be worth just attending for as they're attending for a few months, and then after you get the feel of the place, start asking the questions, because those are the people who could make this, who could really make things happen.
We also have
Josh, oh, I'm sorry.
Go ahead, Valerie.
Josh, to your point, there was a really wonderful medical group from UMass Memorial in Plumley Village for years and years and years, and that closed down. I don't know why. I don't know if I ever knew why, but that was in one of those marginalized neighborhoods, and it was so impactful for them, and now it's not there anymore. So where do those people go, or where have they ended up? I think is exactly what we're talking about. Do they still get that care?
So
I agree.
Go ahead, PY.
Oh, I was going to say, Josh, the urgent care piece, I guess I would actually ask to work on the other end, because, by the time you're going to urgent care, you're half a step away from coming into the hospital. So again, you're sort of dealing with the tail end of the process. Whereas really what I think would be my own personal opinion would be that you go to the beginning. You want to go out to the community and find out what people really need out there. It's easy to say once you're sick, we can do something for you, but it would be best if you could keep people from getting ill, if you could get them engaged in the healthcare system to prevent them from, coming in after 25 years of untreated diabetes. Going out to the community, and that can be through the school, that can be through the hospital. Our students do it already. They service a very extensive network of free clinics, a lot of them, and they find it incredibly enriching. So there are some good efforts like that do help people that have limited resources and are, principally patients of color. So that's one place to start, but there are many other ways we could go out and engage community groups, which we're starting to do, but we haven't done a great job in the past.
I think that brings the importance of how do we create policy? How do we do policy advocacy, and not, how that public policy is created and how we can, as leaders, how we can create lasting community partnerships. So where are, this associations, this organizations in the community that we can create a connection to make that feedback loop and make that relationship grow stronger, not only momentarily, but perpetuated through time.
So I just want to reply to PY, because being a physician, you probably take care of all your family's minor problems. And so, but I can say for my family, when the Fallon Clinic, which was originally on Plantation Street, opened up an urgent care center, we went there all the time and used it. I mean, because getting an appointment with the physician might take longer. And the reason why I say this is it's an inroad is because there are now physicians who have their office at these, at least in the UMass part, at these urgent care centers. So it's one way of entry, and it's not the only way. I think going out and doing other things, and these clinics, these free clinics in Boston, have been doing great work.
So we do have a question in the chat. Are there resources and examples of changes I can make in my educational materials and curriculum in general that make identifiable improvements?
So I think there was a link to a website that sort of preceded this this session that I would encourage people to take a look at. And then also in general, I would encourage education to include information about sort of historical and social and societal context. So one thing about medicine is that it tends to be highly individual focused, which is important, but at the same time misses out on some of the larger picture. So for instance, so I'm a mental health, professional. So I've definitely in one of my discussions pulled in discussions of in the 1800s, there was the diagnosis of Tripetomedia, which is basically this affliction of enslaved people that makes them run away from enslavement. And this was identified as like a mental disorder, and the treatment for it was whipping. And this sort of laid the groundwork of just the development of, mental health, like clinical science, and what we consider to be a mental disorder, what we consider treatment, and just saying like, we're not infallible, like just kind of, this is where we're coming from, and this is the impact that it's had. And it's also really helpful to acknowledge the varying contributions made by members of marginalized and minoritized groups. So, maybe, yes, the first, Black person who got a degree in whatever and did whatever, and that's definitely important and worthy of acknowledgement, but also consider the role of the women who, the enslaved women who, during the development of the science of gynecology, were experimented on without anesthesia. And, discoveries from that sort of propelled the field, and acknowledging that, and just knowing that aspects of our field and our society were really built on the backs of others. And then also make promotion of equity an ethical obligation as part of, practice and your field. Just really sort of examining societal harm and the way that our fields have perpetuated that harm, despite being, intended to be helping, and acknowledge that, and really kind of be thoughtful about how to move forward and how to benefit people, not only in practice, but then there's other ways to do it, such as in advocacy and talking to legislators, especially as people, who have or are developing some highly specialized and advanced skills. There's a way that you can turn that to the benefit of the community beside, just, practicing in your office. So encouraging people, especially students, to think about that. And then I don't mean to go on, but I just want to make one more point. I have noticed that students in particular tend to be more aware of these issues, and they really do want to discuss them. But I think they could probably be discouraged by hierarchy, by their own inexperience, and sort of lack of awareness on how to get information and how to get support, and where to get support from, whether it's sort of informal mentorship versus the formal sort of resources that have been implemented by the Diversity and Inclusion Office. Students want to talk about this, but aren't sure how or whether it's their place. And so to just be aware of that. So anyway, I'll leave off there.
This education piece is so important. And actually it kind of remind me, like going back into medical school, once you're in the dermatology section, and you study like melanoma and skin cancers, the majority of the pictures are white skin. Even that simple aspect in medical curriculum might have a lasting effect if we could advocate to change that. I know PY has been working, in this space a lot, but implicit biases is a really good starting point to educate. I think from a system-wide, try to implement that on a system-wide, it's a little bit challenging. We have standards of respect, which doesn't fit the whole purpose, but we need to relook at not only on a faculty level, employee level, but also education on a medical school, nursing school, even on the small detail.
So I'm going to actually, thankfully, be able to shed some positive light on some of this. I actually think that the students are not shy about bringing these issues up. They're actually incredible drivers of this. We see this in training too. The medical residents are pushing much harder than faculty on these types of issues. And I think that's the reason I'm actually very hopeful that we'll actually get something done. Yoel is very nice to comment about work that I'm doing on this, but the real person who's driving this is actually on this call, Yasmin Carter, who is heading up the Health Equity, Diversity, and Inclusion curriculum group for the medical school as we revise our curriculum. And the whole idea here was to introduce more material regarding bias and racism, and to figure out how to place it strategically throughout our curriculum, not just in sort of obvious one or two obvious lectures, but to build it so that people learn about this as they go through all 4 years of medical training. So I think there are efforts working on with the medical school and students in education, and it ought to happen at every level, at the faculty level, at the resident level, at the staff level. I can tell you, when I look at our staff, the same leadership issue is there. I rarely see managers who are people of color. It's amazingly non-diverse.
Other
I
questions?
mean, with this COVID, 18 months of COVID, all of a sudden I've seen advertised at the medical school. There's a graduate student group. There's a undergraduate, a graduate school of biomedical sciences, and then there's a medical school group. So there are lots of groups that have popped up with the beginning of COVID. Now, I don't know how much of this was due to Floyd's murder and how much was due to just having some time to think. But so I think now, as I look at it, there's a lot going on here for students. And you're right, PY, it's actually the students who are doing these things and trying to convince the faculty or educate the faculty on what the problems are.
I actually forgot to mention that Jules Troba is also a big driving force behind the Hetty group too. But the students will help us. We need to help them, and we need to listen to them. And that's really one of the things that I think I think Natalie already mentioned, that they need support, because more often than not, that enthusiasm gets blocked. It happens, far more frequently than it should. And so if you see this, we need to sort of help them.
An excellent point. And I think too, a lot of the work that they are doing, particularly those that are from marginalized identities, it's in an effort to survive their time here, right? So they need to do this in order to make sure that they complete the degree that they're here to do. So that is a great point, PY, that we do need to make sure that we are committed to helping them and not just kind of using them for the efforts that they're putting forward.
Mm-hmm.
I would also encourage not thinking of, sort of the student work as the beginning of the process, because really it should be beginning with like recruiting and getting people applying and in the door. Once you wait for, when people actually arrive, it's a little bit too late, because, you know, inequities show up in college admissions. And, you know, when you think about things such as imposter syndrome or stereotype threat, you know, and isolation, you know, so it's really important to be mindful and really intentional and thoughtful about recruitment efforts. And, you know, this is recruitment of students, but also faculty and staff.
I saw that we had another question. Was that Anne that you were?
Yes, yes, thank you so much. So just to introduce myself, I'm Anne. I'm actually a nurse practitioner, and I did most of my schooling here at UMass Graduate School of Nursing, and I'm currently working in primary care here at UMass as well. And I find that this conversation is so important because every time somebody speaks, I have something to say about it, because it's been so, you know, in the forefront for me. As Natalie said, that there's a lot of, you know, isolation in where I'm at as a nurse practitioner. And also Joel, I think, came through our clinic as a resident, and he, I think, would attest to this, that there's a lack of diversity in the providers. In addition to this, you know, the patients that come through are actually quite diverse. So it is difficult sometimes for people to, you know, let down their guard and actually tell you what their concerns are, because of that mistrust that has been built over the years. Coincidentally, I also am faculty at UMass Graduate School of Nursing, and again, to Natalie's point, there is a lot of, you know, I feel like there's a lot of isolation in that piece, because it appears that I'm always the pioneer for everything. You know, I am the only person of color in my department as a provider. I'm one of the only, you know, people of color in, you know, in education. And I just wonder, as an, you know, as an entity, how can we work together, not just the Graduate School of Nursing being on its own, but also the medical school coming together to try and remedy this, because when we work in isolation and in silos, it becomes a little bit more difficult to tackle this huge problem that we have. And I'm just wondering what other resources are there for, you know, people like me and people who are out there working alone, and what we can do to actually improve this, not just for myself, but also for the entire community, just the community here at UMass, but also the community that we serve. And thank you for this opportunity.
Yoel, I don't know if you wanted to talk about your listening group, because this sounds like a good segue to expanding that.
Yeah, actually, we had this is for the Department of Medicine. We had our first underrepresented minorities in medicine listening session back in August. And the plan is to do this regular. And this was sparked mainly by just going out there to the faculty and asking them, I was just, you know, what's your feeling about diversity in the Department of Medicine? And actually what we've talked about today, those are the same concerns that many of them had. Like, I didn't know, one of them was that I didn't know we were doing diversity work. And that just to tell you like how narrow their vision is just coming clinically, work and get home, and that's it, and not getting engaged in what the community is doing. The other was saying, I don't see anything beyond my division. I don't see anything. I don't see any connection with other divisions. So there are many things that to tackle with, and actually that was one of the main driver to come up with this, you know, listening sessions. We had our first one. Hopefully, we'll be scheduling the second one just to get them talking, provide that space for our faculty to talk about their experiences, to share their ideas, but not only that, just to engage them. It's the best opportunity to engage them and use their talents, use their knowledge into this work, into projects, into you know, ideas. So that's one of the aspects that we're doing in the Department of Medicine. I'm on other things, and that, you know, is to tell you that we need that type of space across the whole system, not only the Department of Medicine. For us faculty members, it's very hard to juggle this dualship of employment. I'm part of the medical school, but I'm also part of the system. How do I juggle that with diversity? Can I be more inclusive? How, and we need this. We need groups forming and talking and sharing what we are experiencing.
So I will share, Anne, that we also have, and these things are all recent, Alana Faculty Network, and that's for faculty of color. So encourage you to be part of that community. We also now have diversity, equity, and inclusion liaisons for each department. And so that is another way to talk about issues or concerns, bring those to the attention of other departments. And we're working with those liaisons to hopefully have some institutional initiatives that go across departments, because I agree with you, lots of things are siloed. There's a lot of good work that's happening. We just are not communicating about it. And so we need to become more strategic about how we are moving the needle. And so those are things that we've started, and we're going to continue to do work that really impacts the entire system and not just specific programs.
One of the things that has bothered me about what has been happening is that the people who you're talking about, or everybody's talking about, are people on the way to the upper middle class, or trying to get there, or middle class, and trying and feeling the way around this medical school. But there's another whole group of people, and that's the people who are working class individuals, those people in EBS, those people who take care of the heating system. There's a whole group of them, and that probably is more diverse than anything else in the than any other area in the school. And I've tried many times to try to get someone representing on the CEOD, but so I guess what I have to say is, do you have, or can you think of having somebody who tries to arrange these kinds of discussions with the working class individuals here? And the white working class knows about this economic divide and knows about the racial divide, but they're affected by the economic divide too. So I think it's more than just the diversity should also include everybody, and that means the working classes.
I agree with you, Josh. And, a lot of this is also structural, right? If we have these committees, that means that you have the time and access to be part of these committees. So you're absolutely right. We need to create other venues and ways for those voices to be amplified. Because the way that the system is structured, it does leave out an entire group of people that are not able to join committees, that are not able to take time out of their day, that maybe they're not sitting at a computer all day. And so they are not part of these important conversations that impact their career at UMass. So again, that's a great point. And we are looking at ways to engage those communities, because we can't continue just to work with a few. And I know we had one more question from Sharina, which will probably be our last question. We're coming up on the hour.
So I had a question that was more of a kind of derivative of Anne's. And my question is, how do we kind of prevent ourselves from feeling overwhelmed with the massive amount of movement that needs to be made? I mean, the group is, the panel has really expertly outlined a lot of the structural and cultural and those types of problems in the system. And so it can seem daunting to feel like we can actually make any kind of real progress in our lifetime. So how do we prevent ourselves from kind of getting overwhelmed?
So a couple things I would say. Good self-care. So there's going to be times where you're going to need to say no. There's a limited amount of time in the day. We all have all sorts of different obligations. Some of us can't be everybody's Black friend. So it's okay. Know your limits. know your boundaries and respect them, respect yourself. And then also, you know, find something that really catches your passion and your emotion and your energy, and you can like focus on that a little. You know, and so maybe you can't do every single thing, but you know, here's one or two things you're really good at. So, you know, focus on doing that. And once again, like self-care, like there's going to be some, you're going to need some downtime, you know, every once in a while, you know, where you just, you know, whatever works for you, if it's, you know, stupid TV or something like that, where you just need to sort of take a break before you know, take a breath and step back out. So those would be sort of my suggestions.
I would add too that we need to remember that this is everyone's work. I think a lot of times those that are in these roles or have certain identities take on the responsibility and take on all the responsibility. But I hope that we can start to shift this work to everyone. And if as a community, we all looked at our sphere of influence and said, I can do this, imagine how easy it would be to push that boulder up the hill. But when it is the same group and the same faces that are tackling this, that's when it becomes very overwhelming. So I hope, you know, to help get that message out there and really help to encourage the leadership to also have that message. This is everyone's job, not just a few. So on that note, thank you all. This was a wonderful conversation. Like I said, we do these every month. So this is not the end of us talking about racism, how it impacts UMass, how it impacts medicine. Have a wonderful rest of your day and come back next month to join us.
Thank you.